In just 2 days.
Yes, 2 days. That's right.
So we're starting at 5 o'clock, no?
That's right.
Mike, can we start?
Okay.
No,
And,
Mr.
and
Mr. Satya will give us the
Okay.
you can go. You can start.
Can start, Mr. Satya?
Yeah.
Okay, yeah, we can start.
Okay. Good afternoon, ladies and gentlemen. And on behalf of the Sri Lanka Society of Gastroenterology, let me warmly welcome you to this webinar, which has been jointly organized by our society and the Asian Institute of Gastroenterology, India. This webinar will focus on both acute and chronic pancreatitis, which, as you know, are very challenging illnesses to manage. We have lined up two excellent lectures to be delivered by two great speakers. And the first lecture will be on endoscopic interventions in acute and chronic pancreatitis and will be delivered by an expert in the field, Dr. Nageshwar Reddy from AIG. It is my distinct pleasure to introduce him to this audience. Dr. Nageshwar Reddy is currently the chairman of the Asian Institute of Gastroenterology, Hyderabad, India. He graduated from Kurnool Medical College and obtained master's degree from Madras Medical College and DM in gastroenterology from Chandigarh. He subsequently worked as a professor of gastroenterology in Andhra Pradesh Health Sciences before setting up the Asian Institute of Gastroenterology, a tertiary care gastrointestinal specialty hospital in Hyderabad. His main area of therapeutic interest has been GI endoscopy, particularly in therapeutic pancreatobiliary endoscopy and innovations in transgastric endoscopic surgery. He has published over 700 papers in national and international peer-reviewed journals and has contributed chapters in 23 international textbooks of gastroenterology and has edited 8 GI endoscopy textbooks. He is on the editorial board of Gastrointestinal Endoscopy, Digestive Endoscopy, World Journal of Gastroenterology, World Gastroenterology News, Gastroenterology Today, recent patents on medical imaging, and gastrohealth.com. He is the peer reviewer of journals like Lancet, Gastrointestinal Endoscopy, Journal of Gastroenterology and Hepatology, and the Indian Journal of Gastroenterology. He was the president of the Society of Gastrointestinal Endoscopy of India in 2001. He has been a visiting faculty member for over 200 international endoscopy workshops and has been a member of the Asian Endoscopy Masters Forum. He has been recognized many times over for his outstanding achievements by several societies. He received the B.C. Roy Award from the Indian Medical Council in 1995, the Padma Shri Award from Government of India in 2002, and is a recipient of the Honorary Doctor of Sciences degree from Nagarjuna University in 2005. He has given several named orations, including the Sir Francis Avery Jones Professorship in St. Mark's, London in 2008, the Peter Gillespie Oration in Australia 2010, the Joseph Sung Memorial Lecture in Hong Kong 2015. He received the Master Endoscopist Award from ASG in 2009, ASG International Leadership Award in 2011. He received the highest award, Master of World Gastroenterology, from World Gastroenterology Organization in 2014. He was the Secretary General of World Endoscopy Organization and subsequent President of the World Endoscopy Organization. He received the Padma Bhushan Award from Government of India in 2016. He received the ASG President's Award from the American Society of Gastroenterology in 2020. This year, he was awarded the Rudolf Schindler Award, which is the highest award in the world for gastrointestinal endoscopy. Apart from all these achievements and accolades, he has been a true friend of the Sri Lanka Society of Gastroenterology and has been a long-standing faculty member at the annual academic sessions, including the one scheduled for this November. He has contributed immensely towards development of gastroenterology in Sri Lanka, and I personally had the opportunity to attend many live endoscopy workshops at his institution. I shall now hand over the proceedings to Dr. Reddy. But before I do so, let me remind the audience to send in any questions on the chat line on the Zoom as well as on the YouTube live. We shall address them at the end of the lecture. Over to you, Dr. Reddy.
Thank you, Sanjeev, very much for that kind introduction. Again, it's a pleasure to be a part of the Sri Lankan Society of Gastroenterology meetings. In fact, I have a very long association with Sri Lanka Gastroenterology. Maybe for last 25 years, I've been there almost every year for their annual meeting, and hopefully, if COVID subsides, maybe we can be a part this year too. I also like to thank Sun Pharma for organizing these eSPACE programs, which again, we've been doing for some time now very successfully. The concept of eSPACE is, of course, in this period of COVID when physical meetings are difficult, virtual meetings are being done. So we selected topics. Normally, we would select one topic and you have several lectures, hands-on and so on. But of course, here you can't have hands-on. So it's going to be predominantly talks. And my assignment here is to talk on endoscopic intervention in acute and chronic pancreatitis. What I'm going to do is to be very brief in this because in 20 minutes it's difficult to cover both the subject. I'm not going to delve into the complications of acute pancreatitis like walled-off necrosis where endoscopy has a significant role, but predominantly talk about what happens in acute situations and in chronic pancreatitis. So, in acute pancreatitis, ERCP has to be weighed against the risks it has with the benefits it can produce. We know that there can be a variety of causes of acute pancreatitis. Gallstone pancreatitis is the one where ERCP traditionally is supposed to be useful, and this is because based on the theory that when stones get impacted at the papillary orifice like this, there's biliary reflex into the pancreas, resulting in acute pancreatitis. And this is a famous OP theory. And therefore, if you remove these stones, you can actually technically resolve this pancreatitis. So this has been there. So the main indication for ERCP in acute pancreatitis is in patients who have gallstone pancreatitis. But it's not as simple as that. If you look at a variety of papers that have come, there have been a huge number of papers. Almost every other year, you have a paper of the role of ERCP in acute biliary pancreatitis, and this is a long debated history. You can see here there's some which support, some which don't, and in fact, the first two studies that came from Leeds and from Hong Kong suggested positive outcomes, and there's a German study which came immediately in the New England Journal of Medicine, which suggested that doing ERCP in acute gallstone pancreatitis can actually be more dangerous to the patient in terms of respiratory distress and so on. So there's a lot of confusion, and this confusion is because there's a difference in each study in the timing of ERCP, exclusion criteria, endoscopy expertise, and heterogeneous groups of patients. The reason why there's a debate at all is that when you do an ERCP in patients with acute pancreatitis, it's not as simple as regular patients because the papilla is very edematous and you can see very often we can't see the opening here. The second problem in these patients, of course, is that if you do an ERCP and if you fail, then the chance of complication is markedly increased. And this can be seen here. A failed ERCP in a suspected patient of gallstone pancreatitis can result in a huge amount of complications and in necessity to re-intervene. So therefore, one has to be very careful and do ERCP only when it is definitely indicated. The potential complications that can occur in ERCP in these patients is not only increasing the pancreatitis as such, but infecting the necrotic segment, increased chance of bleeding, cholangitis, and so on. So therefore, to be sure that you are dealing with gallstone pancreatitis, one can make sure you have stones in the bile duct before an ERCP by doing an endoscopic ultrasound. Now, most of the studies that I showed you were actually done before US era, but now with the US era, you can make out stones like this in the common bile duct very well, and therefore you can be very precise about your indication for doing ERCP in these patients. So this was a study, which in fact one of the first studies which actually looked at this problem. 140 acute pancreatitis patients were randomized to endoscopic ultrasound or ERCP. Those who had an endoscopic ultrasound done, who had a positive CBD stones, then underwent ERCP with a morbidity which was only 7%. But there were a group of patients who went directly for ERCP, And in this group of patients, you see 40 out of 70 did not have CBD stones. And the morbidity here was 14%. So unnecessary ERCP can give rise to increased morbidity, and these are the patients who can go into problems. And we all know that then when there is a stone in the CBD, it's much easier to cannulate when there's no stone. And therefore, you can see very clearly that the stone is very important. And this was actually a systematic review of this. You can see that morbidity in patients who went directly for ERCP is much higher than those who went for EUS followed by ERCP. So, concluding from all these studies, it's the strategy that we use is that in all patients with suspected gallstone pancreatitis, before you do an ERCP, you should do an endoscopic ultrasound. And if endoscopic ultrasound shows stones in the bile duct, then you can go ahead and do an ERCP. So, certain things are very clear. For example, if you have a patient with cholangitis, then you do an urgent ERCP. The only indication for ERCP in patients with acute gallstone pancreatitis is cholangitis. If there is no biliary obstruction, no stones demonstrated, no cholangitis, of course you don't do any endoscopic intervention. But there are a group of patients who have biliary obstruction, that is LFT is abnormal, an endoscopic ultrasound showed stones in the bile duct, but there's no cholangitis. Should we do an ERCP in these patients? That is a bland obstruction with pancreatitis. Should we go ahead and do an ERCP? This was something we have not answered till recently, and this study from Lancet actually looked at this very carefully. And this was an urgent ERCP in patients with splenectomy, those who had gallstones, predicted severe acute gallstone pancreatitis. This was a randomized study from Netherlands, and you can see that early ERCP resulted in cholangitis, which was less than 2%, whereas conservative treatment resulted in cholangitis 10%. So if you leave a gallstone in place, even if it doesn't have cholangitis, as the disease progresses, they will develop cholangitis. And therefore, the consensus is, although there's no need for urgent ERCP when there's gland obstruction, you can do it along the course of the treatment. Now, when should we do an emergency ERCP? It should be done immediately at 6 hours or 72 hours. Can you wait? In general, the consensus now is that emergency ERCP should be done before 48 hours. That is, after the onset of the disease, before 48 hours. Now, why 48 hours is the cutoff period is very important is that it's been shown that pancreatic necrosis becomes extremely large after 48 hours. Before 48 hours, if you can remove the obstruction, these patients do not go into more necrosis and so on, and then there's benefit from ERCP. Again, it's very important to distinguish between what you do in an urgent situation like this when you don't have much help. For example,
planned ERCP, you have everybody there. So it's very easy to do the ERCP. But an urgent ERCP, you have only one person to help, no good assistance, and it becomes very difficult. So that's the reason why one has to plan this ERCP very carefully. So the indication for ERCP as an emergency in a patient with gallstone pancreatitis is presence of cholangitis. This is the only indication now. So if you have cholangitis like this, a gallstone impacted in the tip, you can do a needle knife splenectomy, and you can see as I take out the stone, there's pus coming out. And these are the group of patients who will definitely benefit in terms of lower morbidity and mortality. So again, just remember, the only indication for urgent ERCP in patients with gallstone pancreatitis is presence of cholangitis. If you have stones in the bile duct without cholangitis, you will have to do an ERCP at some point of time, but it need not be urgent. You can do an elective ERCP. Just to summarize some of this, what I said, that if you have a mild or severe pancreatitis, it's cholangitis which determines whether you do an ERCP or not. If there's no cholangitis, even if it's severe gallstone pancreatitis, only conservative treatment, no ERCP. If there's no cholangitis but bland obstruction and endoscopic ultrasound shows CBD stones, you can plan an ERCP. It need not be urgent, you can do it anytime. Of course, there's no biliary obstruction, still conservative treatment. So I think now, based on these several studies that are available in literature, it's become quite easy to decide which patient should go for urgent ERCP towards which patient should be treated conservatively. Okay, so that finishes the acute pancreatitis. As I said, I didn't want to go too much into complications of acute pancreatitis like Vaughan, pseudocyst and all, because that's a separate chapter by itself. The next area where endoscopic intervention helps is in patients with chronic pancreatitis. And this is where it's becoming increasingly important as an alternative to surgery. If you have patients like this with chronic pancreatitis, the cause of pain could be a strictures like this with dilated ducts or stones impacted here. So the main indication of intervention is pain. These patients have malabsorption syndrome and also diabetes. These two will not change with intervention, and therefore the only indication is pain. The intervention can be medical, endoscopic, or surgical. What is important to remember before intervening in this patient is the pain in chronic pancreatitis is a very complex phenomena. One cause, or at least in 2/3 of the patient, the cause could be ductal hypertension because of an obstruction, because of stones or strictures. But local inflammation, oxidative stress, and so on also play a role. And what happens is over the years, as these patients develop pain, there's also what is called pancreatic neuropathic neuroplasticity, which complicates the whole affair. And then the central neuroplasticity. So at certain stage, say beyond 5 years, even if you relieve the obstruction, these patients don't have relief of pain because of this central neuroplasty, where the brain thinks there's still pain coming from the pancreas. So early intervention is important. Now, how can we relieve the obstruction? One way, of course, is like in CBD stones, you can do a sphincterotomy, try and take out these pancreatic stones. In this case, actually, the stone is impacted at the ampulla. I'm putting a snare around this and trying to pull out these stones. It takes some effort, but eventually these stones can be, you can see this stone, I actually have a leg on the Ercp table and pulling out this large stone, which is 5 centimeters in length. You can see the stone is trying to come out, and you can see a lot of fluid around that area. And that's the reason why this patient had such severe pain. The stone was causing obstruction. And as soon as the stone was pulled out, a lot of fluid gushed out. And this patient had a fairly dramatic relief of his symptoms. But in general, pancreatic stones are not so easy to take out endoscopically. And this is a picture that my surgical friend G.V. Rao has given me. You can see that even at pancreatico-jejunostomy, these stones are not so easy to remove because they are spickled and they sort of get stuck into the mucosa, into the side branches. So even trying to remove them with baskets or balloons is not possible in most cases. So pancreatic stones cannot be removed so easily like CBD stones, and you require certain other methods. And this method is what we use commonly in extracorporeal shockwave lithotripsy. So these stones have to be subjected to extracorporeal shockwave lithotripsy with the lithotripta like this, and then do a sphincterotomy and remove the stones. The principle is to break these stones into less than 3 millimeters in size, and then they'll come out. As you can see here, you can clear the duct. So extracorporeal shockwave lithotripsy forms a very important component of treatment of chronic pancreatitis. And unless you have a good machine, you cannot do pancreatic therapy. In fact, unfortunately, the urological machines that are often used are not effective for this. We have a very specific machine which is useful against pancreatic calculi, and unless that is there, you can't do these cases. Based upon the evidence, the literature, ESG recommends, and actually we are part of this recommendation, that patients with pancreatic stones with obstructive main pancreatic duct, extracorporeal shockwave lithotripsy followed by endoscopic extraction of the stone should be the first treatment based on level 1 evidence. But what are the factors that influence success rates? There are many gastroenterology endoscopists who tell me that, okay, I've subjected the patient to ESWL, but the stones are not breaking. There are several factors which influence whether the stones break or not. First of all is the patient factor, stone size and density, the presence of a stricture, which these patients often have, the duration of the disease, and use of narcotics. The technical factors like the operator experience, the type of lithotripta machine that we use, the use of epidural anesthesia, and use of secretary. So let me show you a bit of this. This is the machine, as I said, we use, and this is very, very specific pancreatic stones. Other machines that are used in urology do not break these stones. So unless you have this, you can't do good, effective pancreatic. This machine, of course, is extremely expensive. So this is the problem with this machine. It costs almost €1 million. The operator also is very important. Operator here is Dr. Vinod, who's been with us for many, many years now. He has this capacity to localize the stones either fluoroscopically or an ultrasound based, and then delivers these shock waves, will ultimately break the stones. The third important factor is they found that use of epidural anesthesia is very effective. If you use epidural anesthesia, the stones can be broken very well, because using general anesthesia or sedation is not good, because these patients tend to breathe very fast and then you can't actually localize the stone. So these are the three important factors which can increase your success, because if you do this, you can break this into very, very small fragments of powder, and most of it can be actually just washed off from the duct like this, and you can see the pre and post ESWL pictures. Sometimes if you do a very good extracorporeal shock erythrotripsy, like in this case, you can see that you don't have to do an ERCP also. The fragmented caliculi keep coming out of the papilla like this, and the dilated duct has now become normal after a few weeks' time. The success of extracorporeal erythrotripsy has now been studied in several meta-analysis systematic reviews, and you can see very clearly here that in 70% of the patients, you can clear the ducts with this. If you don't have this ESWL machine, or if you have a pancreaticoscopy, you can use this to break these pancreatic stones. Like in this case, you see, we are fragmenting using a pancreatic scope using EHL. But this is not often easy, as the pancreatic duct has strictures. Access to the stones is not easy, and I wouldn't recommend this as a primary method. We can actually also do using a cholangioscope, the SPICE scope. You can go inside and you can see this very nicely, this caliculi. And using a laser, we can break this caliculi and clear the duct. As I said, these are all not very usual in clinical practice. Very often we use only extracorporeal shock erythrotripsy and clear the stones. Now, what is the clinical experience with this? This is the world's largest series that we have published recently. 5,000 patients of chronic pancreatitis who underwent extracorporeal shock erythrotripsy, complete clearance of the duct in 72%. So this less like surgery. Partial clearance in 17%. Only in 10% of the patients, it was not successful. So one can say that in 90% of the patients, you can successfully fragment the stones completely and clear these ducts. The issue is, can we say which patients are likely to respond and which patients are not likely? Because this is a costly therapy. You're going to send them for extracorporeal shock wave, then endoscopic therapy, and so on. There are factors which are there, stored by the study from David Whitcomb's unit in Pittsburgh. Age at diagnosis. Those with constant pain don't respond very well. Those on daily narcotics don't respond very well. Those with the disease of more than 5 years don't respond very well. So endotherapy is effective when the stones are in the head region, the disease duration is less than 5 years, the pain is intermittent, not continuous, patient has not used narcotics, especially non-smokers and non-alcoholics. Just remember this group of patients, they're the ones who are most effectively treated endoscopically. Now, one of the important issues in these patients is how good is this therapy in long-term basis, because chronic pancreatitis is a long-term disease. Most of the surgical treatments are aimed at long-term relief. How does endoscopic therapy compare with this? This is the first study which was done sometime back by Jack Davies' unit, who followed their patients with chronic pancreatitis long-term. And you can see that even after 11 years, these patients had efficacy of the treatment in terms of reduced annual hospitalization or a need for stent exchange. This is our own study published in J Endoscopy Term, where we looked at two groups of patients, those who were followed between 2 to 5 years and those longer, up to even 10 years, these patients were followed. You can see that there's complete pain relief, even on long term, in almost 70 to 60% of the patients. Reintervention is required in a small group of patients because of stone recurrence. In all these patients, reintervention could successfully treat the patient. So in general, endoscopic therapy is very effective even on a long-term basis, and many of these patients can be treated very effectively by the combination of ESWL and endotherapy. But if the patient has strictures like this, which occurs in about 30 to 40% of the patients, endoscopic stenting must be done in these patients. And we have changed the technique of stenting. In fact, earlier we used to put single stent. Now, based upon the experience which came from Guido Costa Magna, we now put multiple stents. So we look at a stricture like this, we balloon dilate with standard balloons, and after balloon dilating, we put in 2 or 3 stents, and then remove the stents after 1 year. So important that stricture should be proximal, multiple stents should be used, and they should be kept for 1 year. These are all very important principles when treating these patients. Nowadays, we have started using completely covered self-expanding metal stents, and this is an example of a bumpy stent. We used in a patient with a stricture like this. We put it for 3 to 6 months, and instead of putting multiple stents, one can put a single stent also. The other forms of endoscopic therapy for pancreatic pain, especially when the pancreatic ducts are not dilated. For example, celiac ganglion block can be done, or peripancreatic fluids can be drained, or you can use rendezvous techniques where endoscopic ultrasound, you put a guide wire, pick it up on ERCP and complete the procedure. Again, I can't go to the details of each of these procedures, but in general, US guided celiac ganglion block is effective for a short period of time in patients with chronic pancreatitis, generally used for malignancy, but in a desperate situation where the ducts are not dilated, we have sometimes used this. There are certain complications of chronic pancreatitis also, which can be treated by endoscopic therapy, and this is an example of biliary strictures. Several years back, we published this in Gastroenterology, where we showed that in patients with chronic pancreatitis, with strictures which are lesser than 3 centimeters, non-calcific pancreatitis, we can actually effectively treat them with completely covered metal stents, which are put for 12 months and removed. And even after follow-up for 3.5 to 5 years, these strictures remain open. So no need for going for surgery for biliary strictures in patients with chronic pancreatitis. We recently published a study where we did a randomized study comparing multiple plastic stents, standard of treatment, versus completely covered self-expanding metal stents for 12 months, followed by 12 months follow-up. And you can see here the stricture resolution, overall adverse effects were similar for both, but the need for ERCP was extremely less in completely covered metal stents. And therefore, we believe that the standard of care in patients with distal biliary strictures with chronic pancreatitis is to put a completely covered metal stents for 12 months and then remove them. Now, there's been a lot of debate in the literature between surgery versus endoscopic therapy. What should you choose in your patient? I think, in fact, several years ago, me and my colleague, we have written an editorial in Clinical and Translational Gastroenterology regarding the need for endoscopic versus surgical intervention of painful chronic pancreatitis. And as you can see from this editorial, what we suggested is that further trials are required. But basically, if you have ideal patient, head stones with dilated ducts, then I think treatment should be endoscopic. But if you have more stones, if you have better expertise, maybe you can do. But if you have a situation like this, multiple stones, multiple strictures, then I think in this type of situation, surgery is better. Endoscopic therapy should not be done. So it's very easy to decide on this. And John Winster is a very reputed surgeon who actually collaborated with me on this article. And you can see now we have a consensus among surgeons and gastroenterologists about what to do in this situation. So when you're managing patients with chronic pancreatitis, especially when you're looking at the endoscopic type of management, you have two approaches, a step-up approach or individualized approach. The step-up approach is what is advocated by some endoscopists. What they suggest is that you have patients with chronic pancreatitis. In all the patients, first try medical treatment. Stop smoking alcohol, analgesics, neuromodulators, pancreatic enzymes, antioxidants. You now also have uncovered pancreatic enzymes, which are useful in this situation. So this, I think, is extremely useful in early stages. If they don't respond, go for endoscopic therapy. If they still don't respond, go for surgery. There's been criticism of this step-up approach because it indicates that you have to use it in all the patients, whatever type of morphology they have. But we now are going into more individualized approach, a so-called precision medicine, where the approach depends upon the morphology of the pancreatic duct. For example, if you have a non-dilated duct, you can try medical therapy. Desperate cases, celiac ganglion block. If you have a complication, you treat these complications. But in patients with a dilated duct, stones, you can do extracorporeal shock therapy. Similarly, single or multiple stones, ESWL. If you have strictures, you put in stents. Both these fail, then you can go for surgery. But if a patient comes to you with a head mass or multiple strictures and stones, then you directly go for surgery without endoscopic or medical treatment. So I think this individual approach is very important. especially involves teamwork of physicians, endoscopic surgeons, and interventional radiologists. And now, I think increasingly, as you can see from our institute, this teamwork is extremely important in treating patients with both acute and chronic pancreatitis, where you require interventional radiologists, endoscopists, gastroenterologists, and surgeons to work together. The best results are obtained when you have this teamwork. Once again, I'd like to thank the Sri Lanka Gastroenterology Society and Sun Pharma for giving me this opportunity. Thank you very much.
Thank you very much, Dr. Reddy, for that excellent overview of acute and chronic pancreatitis and the endoscopic interventions. And I'm sure you will be happy to take up any questions.
Do they come on the chat box? Or?
Yeah, they're supposed to be coming on the chat box. I don't see any so far. Sri Lankans are not too.
That's right. Huh? No, there are questions. Actually, I can see them.
Let me ask a
there
few
is,
questions.
I think there are some questions, sir. Yeah.
Oh, okay.
Yudita Dasanayaka is asking, how many ESWL sessions does a patient with chronic pancreatitis require on average? Thank you, Udita. In general, patients with chronic pancreatitis, depending upon the size of the pancreatic stones, require a number of ESWL. If the pancreatic stones are 1 to 2 centimeters, single session is sufficient. If the pancreatic stones are more than 5 centimeters, multiple sessions. 40% of our patients, single session is required. In about another 30 to 40%, 2 sessions, and small percentage, 3 sessions. The reason why we limit these sessions is that you can give up to 10,000 shots per session. So if in 10,000 sessions you can break the stones completely, then of course that is sufficient. So it also depends upon the stone density, stone size, and also the spread of the stone in the pancreatic duct, associated strictures. So all this will determine. The next question Ilta has asked is, what is the approach to patients recurrent acute pancreatitis found to have pancreatic duct strictures? I think again, this is an important question, that if we have recurrent pancreatitis in the stricture, when you treat the strictures in this patient, then of course they respond to therapy. But important to make sure that this is not a malignant stricture. Now, malignant strictures are usually made out by brushings and so on. There's a fear that you should not brush in the pancreatic duct. This is not right. You can. If it turns out to be malignant, of course, patients should go for surgery. But in many of the strictures, if you can pass your guide wire, dilators, and put in multiple stents, you can treat these patients effectively endoscopically. Another question from Shivan Chetty. In chronic patients with stone in MPD, having pain but pancreatic pancreas atrophied, is there any role for endotherapy or in LPG? So I think the main indication for therapy in patients with chronic pancreatitis is pain. It doesn't matter how much pancreatic parenchyma is left, because pain has to be treated. If pancreatic parenchyma is atrophic, obviously these patients' exocrine or endocrine pancreatic functions do not improve. But this can be substituted with either enzyme therapy or therapy for endocrine insufficiency. But pain is the one which we have to treat. And for treating pain, we relieve obstruction, either endoscopically or surgically. As I showed you, there are clear-cut indications for endoscopy versus surgery.
If I may ask a question, Dr. Reddy?
Yeah, please.
In our country, one of the main drawbacks in treating these patients is the access to ESWL. So in that situation, do you recommend us to try ERCP, or do we need to straight away prefer for the surgeons?
Yeah, I think Sanjay, that's a very good question. In fact, we get a lot of patients from Sri Lanka center because of this lack of ESWL. Now, unless you have very good ESWL machine in the gastroenterology department, this should not be in the urology department, it should be in the gastroenterology department. You should have a trained operator who is doing only these cases, and you should have anesthesia people capable of giving epidural easily. When you have these 3 things only, then your success rate is very high. If you don't have a proper ESWL setup, then you should not attempt ERCP, because ERCP, there's no point in doing diagnostic ERCP in these people. MRCP will give you the full anatomy. If you do not have this, then I think these patients, if they have pain, then should go for surgery and not endoscopic therapy. Endoscopic therapy in chronic pancreatitis is a combination of ESWL with ERCP and not plain ERCP. In fact, that's the reason we get many patients, again, as I said, from Sri Lanka who had ERCP and stent put in. They don't get relief because unless the stones are cleared. Once these patients undergo extracorporeal shock lithotripsy, removal of the stones, and then they get cleared from that and they get relief of pain. There's one more question, I think, which is, yeah. This is Hachita. What are the antioxidants used in pancreatitis and what dose? I think this is going to be covered by Dinamitra, so I won't go into the details of this, but our center has published a large study on different antioxidants and what specific antioxidants and what doses are going to be useful. This was published by my colleague Rup Jyoti in World Journal of Endoscopy. I think Dinamitra is going to cover that, so I won't go into it.
Another question regarding strictures, Dr. Reddy. After placing a plastic stent, how long should you keep it to see the efficacy of?
Yeah, this is a good question, Sanjiva. First of all, there are several principles in stenting in patients with strictures with chronic pancreatitis. First principle is that single stent is not enough. Majority of these patients, you have to put either 2 10-French or 3 or 4 7-French stents. Now, how do you put this stent? You can't put them in the first sitting itself. So we put one, dilate it to the balloon, put one stent, and then come back after 3 months, put the second stent. So this is how we would do that, because you can't do it at the same sitting. That is one. Number two is in these patients, the stents have to be put for sufficiently long time. One of the mistakes that people make is put the stents for 3 months, remove them. He'll get back recurrence of pain because the strictures are very fibrotic, they reform. So what we would suggest is that after 3 months, assess the patient, but the stents are in place, at least 2 stents, and then the stents are taken out after 1 year. Hopefully, during this 1 year period, the patient should be pain-free. If the patient is getting recurrent pain even after stenting, then we try and put additional stents to open up the stricture further. And if additional stents are useful, we continue for 1 year. Now, if even after stenting, the pain doesn't come down, obviously the cause of pain is not because of obstruction. There can be a neuropathic component, and these patients, of course, will have to think of alternative methods of treatment.
So in the sequential dilatation of these strictures, when would you consider putting a metal stent?
Yeah, this is again very important. So metal stent is decided in the beginning itself. If the patient could afford a metal stent in the beginning, we tell them the choice of putting multiple plastic stents or a single metal stent. So if they want a single metal stent, we put it upfront in the beginning itself. Then you don't have to do sequential ERCPs. And then the metal stents, the only difference is metal stents, we tend to remove a little earlier than plastic stents. Multiple plastic stents, we put for 1 or sometimes even 2 years. Whereas metal stents, we remove by 6 months. The reason is the tip of the metal stents can cause a little damage to the distal can produce stricture. So that's why 6 months is what we use. Multiple plastic stents, we remove after 1 year. And some of the patients get back the pain. They say that then we go in immediately and put in for another 1 year, and many times 2 years is required in these patients.
Thank you. See any further questions on the chat line?
Yeah.
So in the absence of any further questions, let me thank Dr. Reddy for an excellent lecture once again. And I hope to see you again, probably at our academic sessions in November, either physically or virtually.
Definitely. Thank you. Thank you very much, Sanjay. Thank you.
Thank you. Thank you. Right. With that, we'll get on to our next topic, which is medical management of chronic pancreatitis, which will be presented by Dr. Nandana Dinamitra. Dr. Dinamitra graduated MBBS with second-class honors from the University of Peradeniya in 2007 and completed his MD in medicine in 2014. He gastroenterology at the National Hospital of Sri Lanka and soon proceeded to the UK for his overseas training at the Luton and Dunstable University Hospital, and the Eden Brooks Hospital in Cambridge. During this period, he was awarded the Registrar of the Year 2018 award by Luton and Dunstable University Hospital and also completed his MRCP UK. At present, he is the consultant gastroenterologist and hepatologist at the District General Hospital, Polonnaruwa. In addition, he also serves as our editor-in-chief of the Sri Lanka Society of Gastroenterology. His research interests lie in hepatology and liver transplantation, therapeutic endoscopy, and chronic pancreatitis, and has been involved in more than 50 liver transplantations. He has been the recipient of several awards, which include Health Services Excellence Award in 2009 and the Presidential Research Award in 2015. Over to you, Dinamitra. Thank you.
Thank you, Dr. Sanjeev. Can you see my slides?
Yes, we can.
Yeah. Yeah. Next, good evening, everybody. Thank you for joining us. Next 30 minutes or so, I will be talking to you about the medical management of chronic pancreatitis. This is a challenging topic because there are a lot of challenges in the diagnosing, the managing the patient, as well as I have another additional challenge speaking after Professor Reddy. So this is published in 1995, the New England Journal of Medicine. It says the chronic pancreatitis remains an enigmatic process of uncertain pathogenesis, unpredictable clinical cause, and unclear treatment. This uncertain pathogenesis, I think we have unfolded a bit over the last few years, and the unpredictable clinical cause is still there, but we have little bit of predictable nature we have understood up to now, and the unclear treatment we have still, there are unclear instances, but there are little bit of clear treatment as well. The definition of chronic pancreatitis, this is a bit older definition where we wanted to define the chronic pancreatitis, proving there is abnormal imaging findings, those are irreversible, and they have at least one of the following three symptoms, like abdominal pain, and the evidence of exocrine pancreatic insufficiency where they do not have enough enzyme to digest the food, and evidence of endocrine pancreatic insufficiency where they have diabetes. But we have a current definition that is in 2016. Chronic pancreatitis is a pathologic fibroinflammatory syndrome of the pancreas in individuals with genetic, environmental, and/or other risk factors who develop persistent pathologic responses to parenchymal injury or stress, where now the genetic things come into play. Although the diagnosis, the histological diagnosis is not feasible in most instances. If you do the histology in normal patients, you can see what's on your left hand side. And in severe pancreatitis, most of the time we diagnose the patient at this stage, the severe stage, where the irreversible damage had been done. So our management is mostly supportive. There are a few key concepts. Like pancreatitis is a complex, and no two cases are alike. So we may have to tailor our treatment individually. Alcohol is a major contributing factor for pancreatitis in some people, but not others. So why this some people? So there must be some other insult as well for them to have pancreatitis. And the genetic background of each person can guide current and future treatments. We will discuss them in later slides. Etiology, this is a famous acronym, the TIGAO, where we talk about toxic metabolite, idiopathic, genetic, or obstructive pancreatitis. So those things, not alone, they come together and causes the chronic pancreatitis. Some lead to oxidative stresses, toxic metabolite, and necrosis and fibrosis, and SAPE or SAPE hypothesis, that is sentinel acute pancreatic events. And the stone and duct obstruction, those things come into play and causes chronic pancreatitis. That is, the chronic pancreatitis etiology is there are multiple possible causes. If we want to have a one best treatment, what we need to do is, like it's depicted in this red arrow, just take off all these risk factors. At present, we have failed to do so. I hope in future we will be able to do it. This is although a bit complicated slide. We'll talk about this progression from acute pancreatitis to chronic pancreatitis, whether we have an opportunity to help. That is what we are trying to do in recent research. There are a lot of people with chronic pancreatitis started from acute pancreatitis. About 10 to 20% of them can develop recurrent acute pancreatitis. Out of them, about little less than half can go into chronic pancreatitis. But there are about 5% bypasses this recurrent acute pancreatitis. They from acute pancreatitis, they directly go into chronic pancreatitis. That is the patient who had acute pancreatitis. There are, if you take all the patients with chronic pancreatitis, about 1/3, they did not have any evidence of previous pancreatitis. About 10 to 20 can have acute pancreatitis. About half of them can have recurrent acute pancreatitis. So there are, that is why this is a bit complex disease. We do not understand it fully. The same thing in a different slide. When you have at risk or susceptible individual, genetically susceptible individual, when they have the injury, they can have acute pancreatitis or recurrent acute pancreatitis, which is called sentinel acute pancreatic event. Then that can lead to early chronic pancreatitis, but at present we are unable to, it's difficult for us to diagnose this early chronic pancreatitis, or the people who are having that recurrent acute pancreatitis who are going to develop the early chronic pancreatitis. Once they have some of them, but some of them will go into established chronic pancreatitis. People who have the established chronic pancreatitis, they will go to end-stage chronic pancreatitis with time. So most of the time we diagnose the patients at this stage or established chronic pancreatitis, where what we can offer is a symptomatic or a supportive treatment. What we can do is there any opportunity for us to help them. But there are risk factors for pancreatitis. There are protective factors as well. If we can tip the balance toward the protective factors, we may be able to help them. So what are the risk factors? Alcohol, smoking, genetics, gallstones or obstruction, and the metabolic, you all know, hypercalcemia, high triglyceride, and other obesity, age. And what are the protective factors? Anatomy, the acinar cells, duct cell flushing, response to genes or antioxidants. Here antioxidants come. If we tip the balance towards risk factors, then you will have the bad outcome. If we can tip the balance towards protective factor and take off some of the risk factors, we can have good response, or we may be able to help the patient with chronic pancreatitis. This is one interesting study. The acute recurrent pancreatitis and chronic pancreatitis, and they have analyzed their genetics, and they found about 55% of the patients who are having that recurrent acute pancreatitis, they have susceptible genes, and about 70% of chronic pancreatitis, they have susceptible gene. So it means that those people who are developing pancreatitis, they are genetically susceptible. Not all, most of them are genetically susceptible. These are some of the pancreatic genetics. We have a lot of things at present. There will be more with time to come. How gene variants affect the pancreas? Some affect the trypsinogen regulation or trypsinogen activity, which is on the left, and some affect the ductal, CFTR, affect the ductal pathology. So as we talked about genetics, when or to whom should we offer the testing? So the people who have recurrent acute or chronic pancreatitis of uncertain cause of early age, we can ask for genetic testing. For unexplained pancreatitis as a child, or a family history of idiopathic chronic pancreatitis or recurrent acute pancreatitis, or childhood pancreatitis involving first or second degree relative. At risk family members of individual with an identified pathogenic gene variant associated with hereditary pancreatitis. Those are the people that we can. Unfortunately, in Sri Lanka, we do not have this facility available. As we all talk about the alcohol as a risk factor, if you take the on the right hand side circle, if you take the chronic pancreatitis patient, about 25% of them are heavy alcohol, take unsafe amount of alcohol. About 11% of patients with recurrent acute pancreatitis, they take very heavy alcohol. But except this 27, those are not teetotalers, except this 23, everybody else is taking alcohol. But men with chronic pancreatitis who have alcohol-induced chronic pancreatitis different, behave little bit differently than the female. Why is that? It's because the alcohol-associated pancreatitis is linked to the Claudin-2 gene, which is located in X chromosome. Women are protected because they have the extra X chromosome. But the susceptible men with this Claudin-2 gene variant, if they take alcohol, they are at risk of developing alcohol-related pancreatitis. That is why there is a difference between the men and women who are taking alcohol. On pancreas and the pancreatitis, the moderate smoking is a stronger risk factor for chronic pancreatitis. It comes before the moderate or heavy drinking. So smoking is like one of the strongest risk factors for chronic pancreatitis. The other thing is because of the chronic pain they're experiencing, they tend to continue the smoking. But the other thing, the heavy drinkers, they are heavy smokers as well. So there is like synergistic effect on the disease progression. We talk about the clinical characteristics of chronic pancreatitis. If you scarring, 70% have pain, about 40% have maldigestion or the exocrine pancreatic insufficiency, and about 35%, 1/3 have diabetes mellitus, and 15% can develop pancreatic cancer. We diagnose it by demonstrating irreversible damage to the pancreas, and we can do it by CT, MRI, endoscopic ultrasound. And we'll treat them with pain treatment, enzyme replacement, and insulin. So the goal of medical management are as follows. So what we have to do is modify behaviors that may exacerbate the natural history of the disease. That is, we need to ask them to stop smoking and cut off their alcohol intake, and enable the pancreas to heal itself. So if ongoing damage is there, we try to reduce the risk factors and determine the cause of abdominal pain and alleviate it. That is like significant presenting complaint of the patient with chronic pancreatitis. Detect pancreatic exocrine insufficiency and restore digestion and absorption to normal. And diagnose and treat endocrine insufficiency. So management of pain, next few slides, I'll talk about the management of pain. What are the causes of pancreatic pain? Are tests indicated in the evaluation of pain, or what are non-invasive treatment options for chronic pain due to chronic pancreatitis? Causes of pain can be pancreatic in origin or extrapancreatic, like in duodenal blockage or bile duct obstruction, or they can have ulcers because of the NSAIDs, the drugs, or they can have narcotic bowel syndrome. They can have some evidence of small intestinal bacterial overgrowth, and they can have pancreatic inflammation, and they can have obstruction of pancreatic duct. It can be due to scarring or stones, as Professor Reddy talked about in previous speech. So stepwise management of pain. So we can try analgesics. We can try simple analgesics like paracetamol. Most of the time it doesn't work. Usually we tend to avoid NSAIDs because if they take lot of NSAIDs, a lot of side effects related to ulcer, peptic ulcer disease. And we tend to give them opioid like tramadol, that helps a lot. And pancreatic enzymes, not very helpful, we'll talk about it later. But yes, there are some preparations helpful in managing the pain. And the nerve blocks and brain modification and CFTR based therapies, these are new therapies. And pancreatic rest, where if they have like if they experience pain after meals, then we can try to rest the pancreas. And alternative therapies like yoga and meditation and endoscopic therapy, surgery, as we talked about earlier. So analgesics is managing visceral pain. So what we can do? Our aim is to increase the threshold of pain so they won't feel the pain. Is one thing. The other thing is to modulate nerves both locally and in the brain. So for that we can use antidepressant like amitriptyline, and we can use gabapentin and pregabalin. We are commonly using. Like if you combine these together, these are not like antidepressant doses. We use like little doses. The combination therapy works well. And we can use cannabinoids and anticonvulsant. Cannabinoids is not licensed in Sri Lanka at present. And the antioxidants. This is like the first one published in 2009 in gastroenterology, the randomized control trial of antioxidant supplementation for pain relief in patients with chronic pancreatitis. I think this is done by AIG team. AIG team, and they showed that using gabapentin or pregabalin with methionine about 2 grams is beneficial, and those research subjects experience less pain after methionine, 2 grams of methionine. But after like 3 years, the Dr. Sirivardhana's team, they said there is no benefit in antioxidants. But the recent American College of Gastroenterology guidelines says we can use antioxidants to relieve the pain. So there is a recommendation. And the pancreatic enzyme for pain, only Viocase, that is only quick release form, help to alleviate the pain in chronic pancreatitis. Other preparations are not helpful in alleviating the pain. We think that it prevents the stimulation of pancreas in response to meal. Pancreatic rest. If the persistent flare of pain related to eating, then we can try to bypass the pancreas. This makes scientific sense, but there are not much studies available. To consider day tube feeding or total parenteral nutrition via PICC lines may help. There is another one, interesting one, the mechanistic approach to pain. There is a subset of people who had total pancreatectomy. They still experience a pancreatic pain. So then they have studied the part of the brain which is like sensing that pain, and they try to modulate that site. So in this NI trial, they try to stimulate that area with the 1 Hertz stimuli and then 20 Hertz stimuli. Then they found with 1 Hertz stimuli, their pain is less, or their pain is inhibited. And if once we like stimulate them with 20 Hertz stimuli, then they get more pain. So they have used it for about few weeks and found reduction in pain and narcotic use in over 70%. This is kind of like phantom limb kind of pain. Like although it's originally originating from pancreas, but later without pancreatic stimuli, they can have the pain. You can try the alternative other therapies like herbs to like relieve their symptoms, acupuncture, meditation, mindfulness, yoga, tai chi. We have a lot of other alternative therapies. It's because our normal usual pain analgesics may not work. That is this is the complexity of the disease. What has happened to like pain in chronic pancreatitis during COVID-19? There are enough evidence, but there is no change. In next few minutes, I will be talking about the exocrine pancreatic insufficiency, where pancreas does not produce enough digestive enzymes, so it results in nutrient malabsorption. chronic pancreatitis is one of the causes for exocrine pancreatic insufficiency, but there are a lot of others in like cystic fibrosis, pancreatic surgeries, and usually in infants up to 6 months, they have some kind of EPI. This is the etiology. Like it can be pancreatic or non-pancreatic. The pancreatic causes is mostly the chronic pancreatitis. Little bit about pathophysiology. Like when we have acid in our duodenum, that will release the secretin. Secretin in turn will secrete the bicarbonate fluid from the pancreas, as well as a fat in the duodenum causes release of cholecystokinin, which causes secretions of the enzymes. Like we think the pain, we get the pancreatic pain because of these stimuli. Like if pancreas is trying to work, then you will get more pain. If you stimulate the pancreas, you get more pain. So if we can cut off this cholecystokinin or secretin stimuli, then we can theoretically reduce the pain. This principle we use in the diagnosis as well. Like if we can give secretin or cholecystokinin, and if we can like collect the pancreatic juice and measure the level of bicarbonate and the enzymes, then we may be able to diagnose this disease bit early. This is called the direct pancreatic testing, which is not available at present in Sri Lanka. It is only available in research centers. It's not freely available to the patients, even in the developed countries. They present, how do they present? They present with like symptoms related to carbohydrate malabsorption, protein malabsorption, and fat malabsorption. Now, what are the symptoms? They can mostly the steatorrhea, the pale oily stools, but you can have steatorrhea or pale oily stool even after like out of gastroenteritis. One thing is the sticking phenomena, where like that the stool sticks in the toilet bowl, the common, and difficult to flush. That you can ask in the history, not only asking the pale stools, which is difficult to flush. And they can have abdominal symptoms like diarrhea, bloating, pain, and gas. And they can have fat soluble vitamin deficiencies like A, D, E, and K and related symptoms. How do we diagnose exocrine pancreatic insufficiency? We can diagnose, we have to prove that they are passing more fat, they are not absorbing enough fat, and they do not have enough pancreatic enzymes. So we can do it by measuring the pancreatic enzymes, or we can do it by 74 fecal fat, which is cumbersome. Or the other things, if they have like suggestive symptoms, what I do is put them on pancreatic enzyme replacement therapy and see whether they improve their symptoms. That in our setups, where most of the investigations are not available, so that is one thing that we can do. So these are the pancreatic testing, the function testing. This is direct testing, as we talked about earlier, like secretin test, cholecystokinin test. Or there are indirect testing like qualitative fecal analysis, fecal elastase level. So typical findings in exocrine pancreatic insufficiency are increased fecal fat and decreased enzymes. So this is a kind of an algorithm to diagnose PEI, EPI. The clinical suspicion is high, then we evaluate the biomarkers and fecal elastase. If it is very low, yes, then high probability of exocrine pancreatic insufficiency. If they have like more elastase, so they are unlikely to be having endocrine exocrine insufficiency. If they have like marginal ones, then we can do the imaging and see whether they have any imaging findings suggestive of chronic pancreatitis. Then we can diagnose it. So management of EPI is a pancreatic enzyme mainstay is a pancreatic enzyme replacement therapy, and then lifestyle modification like stop smoking or alcohol abstinence, and diet, small frequent meals, and normal fat intake. And we need to follow up the patients like for the symptoms of maldigestion, weight, and BMI. And this is a little bit about like dosing based on the age. Like for the infants, it's about like 2,000 to 4,000 units for the 4 ounces of formula or breast milk. The child less than 4 years of age, about 1,000 units per kg per meal. and the 500 units per kg per half of that for the snack. The adult and the children more than 4 years of age, they can have 500 units per kg of meal for the half of that for the snacks. Dosing, like there are a lot of preparations available. What we have here in Sri Lanka is a crayon, and Viocase is not available. That is the only thing which is effective for the pancreatic pain. And when we put the patient on pancreatic enzyme replacement therapy, we have to advise the patients. This is very important. Like just giving the pancreatic enzyme, prescribing it may not help. So enzyme capsule should be taken whole and do not crush, chew, or hold the capsule in your mouth. If you do so, the enzyme will release in your mouth, and you will have the soreness of your mouth in your mouth. They take the enzymes capsule at the start of the meal, snack, or drink. Take them with a cold drink, as hot liquids can damage the enzyme because it is a protein. If meals are larger, if it takes longer time, you can take the half of the dose initially and then other half in the middle of your meal. If you have like a lot of fat in your meals, you can like double the dose of enzyme supplementation. But if you have like difficulty in swallowing the larger tablets, you can ask for the smaller tablets. Yeah, you may have to take a lot of tablets. And the diet in chronic pancreatitis is about like daily diet of about 2,000 to 3,000 calories, consisting of about 1.5 to 2 gram of per kg of protein, 5 to 6 gram of kg of carbohydrate, and from that, like about 20 to 25% of total calories consumed as fat. So we do not restrict their fat even in exoplanet pancreatic insufficiency. And we need to replace the other fat-soluble vitamins as well. We have to do it with the meals. Otherwise, they may not be able to absorb them. So with the meals, you need to replace them with the pancreatic enzyme replacement therapy. And I told you that in my initial slides, there are about 15% can develop pancreatic carcinoma. But we do not have enough evidence to suggest that performing pancreatic malignancy is beneficial. So like that 15%, still we do not have a clear guidance. So like mostly like medical community is interested in COVID-19 these days, but in chronic pancreatitis and COVID-19. There are few studies, the prevalence, risk factors, and critical outcomes of COVID-19 in patients with history of pancreatitis. There is no change at present. In this study, they haven't seen any difference. And these are other things that because of the vaccination, COVID vaccination, a lot of patients. Does COVID-19 causes pancreatitis? I don't know, I can't answer it correctly, but whether it causes or not, but there are people with pancreatitis associated with COVID-19 vaccines. So I have managed about two patients, currently I'm managing one. And does the vaccine cause a flare-up of pancreatitis? As far as I know, it's not, it does not. And I have, if the patient asks, if I have chronic pancreatitis, should I get the vaccine? Yes, if you have an opportunity, yes, get the vaccination. I have chronic pancreatitis that possibly is autoimmune related. Is it safe to have the vaccines? I think yes, but it depends on the immunosuppression that you are on. I have chronic pancreatitis and have not yet been put on the list for the vaccine. What should I do? If your country is like vaccinating you, yes, go and get listed. I have chronic pancreatitis due to genetic condition. Am I at high risk and should I get the vaccine? Yes. Irrespective of pancreatitis state, yes, it's better to get the vaccination. Any questions? Shall I like finish the next slides?
Yes, we'll finish the lecture slides. Yes, thank you.
Yeah, okay. I think I have finished almost all. So next, I would like you to invite for our annual academic sessions, very likely to be hybrid, to be held on 11th and 12th of November in Colombo. please join us in that. And in Sri Lanka Gastroenterology newsletter, we have an article on chronic pancreatitis on page 4. Like it's on our web, will be on our web soon. So please go through. And I would like to thank Sri Lanka Society of Gastroenterology for giving me the opportunity, as well as the Asian Institute of Gastroenterology, Hyderabad, and Professor Reddy for helping us, and the Sun Pharma team, the Sri Lankan and Indian team, Jyoti, Mayank, Delanjan, Samad, especially Kumar, Ajit, and Nuan, for helping us. Thank you very much.
Thank you very much, Dinamitra, for that fantastic lecture on chronic pancreatitis. Right, cleared many doubts which the audience had. See any questions on the chat line? Apart from a comment saying that you have explained the lecture very nicely. If I may ask a couple of questions,
Yeah, please. Yes, please.
Now, in the workup of a patient of chronic pancreatitis, we know that autoimmune pancreatitis can be the cause in a few.
Yes.
So, if there is no obvious etiological factor, do you routinely screen all these patients with immunoglobulin levels, or how do you go about it?
Yeah, one thing is like the imaging findings, they have like peculiar associated pancreas, like edematous pancreas. Like if we like initial workup, if you do not find anything, yes, I recommend you to like go for like go for IgG4 levels. It's a bit difficult to like get it done in our setup. I think we may have to send blood to India.
That's right. Yeah. So. Yeah, the importance there is that if we do diagnose it, there is specific treatment for it.
Yes, yeah, that is one of the like few which is like treatable.
Exactly. We come to the management of pain in these patients. In your practice, do you first start off with say a tricyclic antidepressant or pregabalin, or do you start off with an opioid?
I usually put them on like usually they are on tramadol, and but at times it's difficult for me to get the tramadol for my patients, like outpatients. So those times I used mainly pregabalin.
The response
about like
is
75 to 150. Yes, response is better, but the response is better with the patients who are on tricyclic, the small dose of tricyclic, like amlodipine about like 12.5 to 25. With pregabalin, their response is, I think, better.
If they don't respond to most of these medicines, at what point would you refer them for, say, US and to look at the pancreatic ducts and see whether there are strictures or anything? What point would you consider that the endoscopic and US interventions?
Yes, usually like about like 3 months of follow-up in my clinic, and then I'll send them to for like the US and celiac plexus blockage is helpful.
One last question. What dose do you generally start the pancreatic enzyme replacements?
Yeah, good question. Usually, like we have in our hospitals about 10,000, around 10,000 most of the time. At times we had about 25,000 tablets. Yeah, 10,000. I use them about 2 to 3 tablets. I don't usually in my pack. I don't use them with the snacks because our people are not taking much snacks. They take like main 3 meals. So about like 2 tablets of like 20,000. For our patients, like although they recommend in international guidelines about like 35,000 minimum dose, but for our people, I think 20,000 works.
Right. In the absence of further questions, we shall conclude.
Sir, there are
this.
few. Sir, sorry to interrupt you. There are few questions in the chat box.
Oh, okay. Let me see that. question is, what is the treatment of fatty pancreas, especially NAFL patients?
As far as I know, there is no like specific management for it, like other than the things that we are doing right now.
There's one more question, sir.
Yeah.
Yeah.
Then
Yeah, the antioxidant one. Like there are preparations with, I think there are about 1 or 2 preparations with about around 2 gram of methionine. I haven't used it, but like evidence says it's helpful.
okay, that's all which have come through the chat line. So, in the absence of further questions, I shall like to conclude this webinar on pancreatitis. And I wish to thank our 2 speakers, Dr. Reddy and Dr. Dinamitra, for 2 excellent talks and for their time in sharing their expertise with this audience. I also like to thank the audience for their participation. Finally, I wish to thank the entire team at Sun Pharma for organizing this wonderful event. Thank you.
Okay, sir. Thank you, sir. Thank you very much for helping us to organize this program. Thank you. Thanks for you and the Sri Lankan Society of Gastroenterology for helping us to organize this eSPACE.
Thank you. Thank you.
And on behalf of Sun Pharma, I'd like to thank all the doctors who present here, the digital form of gracing in this occasion in spite of their busy schedule.